Dear colleagues, we welcome you to the first of our MENA GMPS and Neuro webinar series. My name is Doğa Vurallı. I'm an associate professor of neurology at Gazi University, Ankara, Turkey. And my co-host is Esme Ekizoğlu Turgut. She's an associate professor of neurology at Istanbul University, Istanbul Faculty of Medicine. Today we have two guest speakers. Our first guest is Dr. Safa Zahlane. She's an assistant professor of neurology at the Mohammed VI University Hospital, Marrakesh, Morocco. She also works at the Clinical and Experimental Neuroscience Laboratory. She's interested in inflammatory diseases, epilepsy, and neurological diseases in children. And today she will present a headache case and then give us a speech on secondary headache disorders. Professor Zahlane, the microphone is yours, please.
Thank you, Professor Doga. Thank you for your presentation and for your invitation too. So let me to share with you my presentation. So I'm glad to share with you this presentation or this talk about secondary headache disorders. So I'll first present you this case report about Mrs. K.A. with 35 years old.
Safa, can you make a full screen?
Okay. It's okay? Now it's okay?
Yes, thanks.
Yes.
Thank you. So I told you this case report about Mrs. K.A., 35, she's 35 years old with no past medical history and who came in the department, emergency department for a sudden onset of headache and dizziness, without any other associated signs. No dysarthria or facial asymmetry, no epileptic seizure or motor deficit. There is no fever or alteration of general status. And her neurological examination was normal, especially there was not any neck stiffness. So for that, we does a MRI, brain MRI. And you see here image of stroke or ischemia in the area of middle cerebral artery. Here, two in a flare sequences. Then we, due to the patient, she is a female and young, we does a CT a scan of cervical artery, which was normal. And doing the cervical artery scan, we found by doing that, we does also a CT scan, which help us to see an image of aneurysm of cerebral artery, middle artery, which lead us to do arteriography showing a saxifor aneurysm of the sylvian artery. And due of a major risk of bleeding, the patient underwent surgery with a very good improvement. And for this case, the onset of headache, which was sudden, severe, and which reached the peak intensity like a thunderclap headache, it was for us a red flag to have an arteriography and diagnose the aneurysm. And aneurysm subarachnoid hemorrhage is a significant global public health, as you know, with a global prevalence of 8.9 million persons. And delayed cerebral ischemia remained a significant complication and is associated with worse outcomes after aneurysmal subarachnoidal hemorrhage. And here there are guidelines of patients with aneurysmal subarachnoid hemorrhage. And for patients with acute onset of severe headache, prompt diagnostic workup and evaluation are recommended to diagnose the aneurysmal subarachnoid hemorrhage. And in patients with acute onset of severe headache who present more than 6 hours from symptom onset or who have a new neurological deficits, we have to do CT scan or lumbar puncture or MRI brain. And headache, as you know, is a prevalent pain problem affecting 48.9% of the population globally. It's a common chief complaint in a patient, emergency department, and outpatient settings. So studies show that headache is among the 10 most common reasons for visits to primary care. Therefore, when we have a symptom which could underline a potential cause, that's a secondary headache. And for the ICHD-3 classification, it provides a list of 8 categories and 46 subcategories for cause of secondary headaches, including trauma injury of head or neck, cranial, cervical, vascular disorders, non-vascular intracranial disorders, substances or withdrawal infection, and disorders of hemostasis, disorders of cranium, neck, eyes, ears, and others, which can 18% of people experience as a secondary headache disorders. And although the majority of headaches in clinical practice are primary, we are, as a clinician, need to be mindful and to try to diagnose or to reach secondary headaches, because the underlying condition can be life-threatening and require a completely different therapeutic approach than primary headache disorders. Here is an overview of the epidemiology of idiopathic versus secondary headaches. As you see here, as primary headaches, tension type, it's reaching in almost 70%. However, as you see, here are 63% as systemic infection underlying secondary headache. So, as first reflex for any physician is to exclude secondary headaches. And really, as you know, primary headaches present 90% as migraine or tension type headaches, but we have to eliminate secondary headaches even if they are only in 10%. Those headaches could be attributed to trauma or injury, cranial or cervical vascular disorder, non-vascular intracranial disorder, and we need to have a brain MRI to diagnose that. But before, imagine, we have, first of all, to look to red flags. First of all, change of semiology, like new type of headache, increase in intensity, increase in frequency, continuous headaches, sudden onset as explosive onset, or omolateral consistently, headaches in very circumscribed location. Also, if there is associated symptoms like nausea, personality changes, epileptic seizures, alteration of general condition, or balance or trouble of balance, of speech, of vision. In examination, we could also find some disturbance in like neuropsychological deficits, papillary stenosis or edema, meningeal syndrome, focal neurological deficits, coordination disorders, fever, anemia, or non-osseous and sinus temporal artery. You see here many causes of secondary headaches, as I told before: trauma, injury, cranial cervical vascular disorder, substance or its withdrawal, infection, disturbance of homeostasis. So always consider secondary causes when we have new type headaches, when there is increase in intensity or frequency, when there is a continuous headaches, sudden onset, constantly homolateral, headaches with very circumscribed localization, and when we have accompanying symptoms like nausea, change, alteration of general condition. The signs and alarm syndrome are neuropsychological deficit, stasis or papillary edema, meningeal syndrome. All these are red flags in headaches. And we have to pay attention to any clinical particularities such as location and duration. Location, generally, we found TMJ as a pain in temples in front of ears, or in sinus as pain behind brow bone and or cheekbones, cluster as a pain is in and around one eye, tension as a pain is like a pen squeeze in the head, migraine as a pain, nausea and visual changes, or neck pain as in the top and or back of head. All those locations are usually seen in primary headaches. So when it's different, we have to look forward secondary headaches. And for general physician, they need to know that there is underlying causes of headaches: intracranial mass lesion, giant cell arteritis, glaucoma, meningitis, and we have to do a very good check and neurological examination for patient. There are other disturbances, especially visual, with the retrobulbar optic neuritis. In elderly, always think about Horton syndrome as unilateral paroxysm of intense burning pain involving eye, maxilla, ear, mastoid, rake. Strong fact in patient male predilection, absence of trigger zone. With intracranial hypertension symptoms, headaches, vomiting, visual troubles, we have to look forward neoplasm by doing brain MRI. We could have also ophthalmological causes, and to look forward, dry eye syndrome, visual problems, scleritis, migraine, sinusitis. Here are the summary of main elements for secondary headache, known as a SNOOP. SNOOP. So S for systemic, history of malignancy, immunosuppression or HIV, or complaints of fever, chills, night sweats, myalgias, weight loss, or jaw claudication, with abnormal systemic examination, including blood pressure and temperature. And for neurologic, focal, global neurologic symptoms, including change in behavior, personality, diplopia, transient visual obscurations, pulsatile tinnitus, motor weakness. O for onset and sudden, peak reach, headache reaching peak intensity in less than 1 minute. Onset, age under 5 or under 5. or after age of 65, pattern changes, progressive headache, postural aggravation, and precipitated by Valsalva maneuver, papilledema, pregnancy, or phenotype of right headache like trigeminal anatomic cephalalgia, apneic, exercise, cough, or sex-induced. Here is just to say a word about difference of migraine and epileptic seizure. There is no any ophthalmic phenomena is migrainous, and migraine progression take minutes as opposed to epileptic progression, which take few seconds and can give way to a menopsia deficit. And epilepsy is another red flag to think about. Other migraine with aura, progression of migraine with aura is clearly different of onset of epilepsy. And I told that before, max duration is 3 minutes for epilepsy. Another key is the diagnostic of epilepsy. The aura in epilepsy is about seconds. In migraine, it's about minutes, 5 to 60 minutes. We have also to think about symptomatic neuralgias instead of any local symptoms and atypical location. In conclusion, among all headaches, 62% are psychogenic or migraine, and 10% are symptomatic. And the fear is missing a symptomatic headache, and the aberration is to request unnecessary paraclinical examination in the face of 90% of non-symptomatic headaches. So we have to be careful and to have careful questioning, good neurological and somatic examination, good knowledge of the different causes of headache in order to ensure good management. And thank you.
Thank you, Professor Zahlane, for your comprehensive talk. I think we have one question from the audience.
Yeah.
From Ece Yanık, she asks you, did this patient have subarachnoid hemorrhage accompanying the aneurysm? How did you diagnose it?
So, to be honest, for the radiologists, they saw a very discrete subarachnoidal hemorrhage. So, for us in the department, the diagnosis was done by doing a CT scan, okay? CT scan. That's what will lead us to see the aneurysm suspicion of aneurysm of cerebral middle artery. Then we do just arteriography and we have the diagnosis.
There's
She
also
has one more
one more
question.
question. Yeah. Please go.
Please, Professor Ekizoğlu.
Was this the patient's first headache, or did she have a secondary history of headaches? Or
No,
just
there is no history of secondary headaches. No, there is no history of headaches before. For the patient, it was a sudden onset. I'll repeat. It was for this patient. It was a sudden headache, severe, without vomiting, without epileptic seizure, without neck stiffness, and she does a brain MRI in the clinic. Then we meet her in the emergency department. We find the stroke image in the brain MRI, and by doing our exploration for the etiology or cause of her stroke, we found the aneurysm of middle cerebral artery.
Careful questioning is very important, as you mentioned during your talk, and the subarachnoid cerebral vasospasm is an important complication of subarachnoid hemorrhage. And it's even this is not an acute stroke, it's very important to perform intracranial and extracranial angiography, MR or CT angiography, whatever you have, as soon as possible for a correct diagnosis. Yeah, thank you. And do you have any question from the audience? Maybe we may wait for some other questions. Or do you have any additional comment or?
In your last slides, you said that among all headaches, 62% are psychogenic or migraine.
Yeah.
Maybe we should, like, what do you mean by just psychogenic headaches?
Yeah. It's headaches in patient with depression, anxiety, and we meet a lot of patients with that headaches or migraine underlying associated with depression and anxiety.
But many primary headache disorders also accompany depression, anxiety. How do you differentiate it?
It's in questionnaire they question patient. So if there is a depression, then headaches, we just know perhaps it's because of depression. But sometimes it's just headache and the patient was underlying medication of depression. So we did the diagnosis as a psychogenic headache.
I also a question from my side. Let me ask it. And I have two questions. What are the most important signs that would suggest a secondary headache, in your opinion? And my second question is, how often do you see any infection-related headaches, and are there any particular infections in Morocco that cause headache?
Yeah, for your second question, we had a case about syphilis, neurosyphilis, for a patient who had just headaches. Then we discover neurosyphilis, and after his treatment by ceftriaxone or penicillin G, he was with a good improvement. For your first question, what's the red flag? It's abnormal examination, neurological examination, when there is deficits, when there is seizures, and there is associated signs, vomiting or blurred trouble of vision.
Visual disturbances are really important to guide us for secondary headaches. I check if there are any other questions.
Professor Akizoğlu, do you have another question?
From my side, thank you, Dr. Safa, for this
Thank you very
detailed
much.
lecture.
Thank you. Thank you.
So I may move to our next speaker, but we may also take questions on Dr. Safa's lecture afterwards. And it's my pleasure to invite as our next speaker, Dr. Hamit Genç. He is actually a neurologist at the Gaziantep City Hospital, and he will talk about an international study of us, all of us from Morocco and from other countries, especially from MENA countries, the had MENA study. And dear Hamid,
Yes,
I give my words to you.
thank you so much. First of all, I would like to thank the organization committee for kind invitation. I am here to present the Hetmana study. It was a very productive study, and the ideal leadership belongs to my dear teacher Aynur Özge. And today we will mention scope, results, challenges, and future directions related to this study to encourage and motivate the other researchers for the next studies. I hope we will achieve this. And in this slide, you can see the publications and awards uh, 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 that produced from the Hetmana study. We published 4 manuscripts in the popular journals. We presented 2 oral presentations. We published 6 posters, and we won 2 awards in the national and international important organizations. It was very productive, and uh, we we decided to this productive study to do uh, approximately 3 or 4 years ago, and we know the estimated global prevalence of active headache disorders is 52%, and headache remains to be underestimated, under-recognized, and undertreated worldwide. Because of that, we aimed to update headache distributions with the ICHD3 criteria and to identify all headache subtypes in admitted patients with headache, since the previous studies were generally performed in accordance with the old ICHD1 and or 2 criteria. The other reason was to determine the distribution of headache types in different settings in the neurology clinics according to the ICHD3 criteria through neurologists, to scrutinize the variation of headache subtypes according to the locations where the research was conducted and the possible factors that lead to the difference in findings. Finally, to compare gender differences, pain perception, clinical characteristics, etc., in patients with headache. We actually 13,734 patients were recruited to the neurology clinics, and approximately 30% of them had a headache, and we excluded 422 patients due to different reasons, and finally, we collected 3,722 patients. In this slide, you can see the countries that joined the study: Turkey, Tatarstan from Russia, Mongolia, Azerbaijan, Iran, Egypt, Ethiopia, Sudan, Chad, Ivory Coast, Senegal, Morocco, and Northern Cyprus. Uh, it was a very comprehensive study, and uh, we uh, we found especially the middle-aged individuals were affected by headache, and neurologists uh, when we evaluate the patient's profile, approximately 1 of 4 of them have had primary headache disorders. Uh, Also, the woman dominancy took our attention. Almost 3 of 4 were women. In this figure, you can see the distribution of secondary headaches in the different regions, and approximately 30% of patients had secondary headaches. Uh, we try to research uh, some points usually not evaluated before. For example, you can see in this table, we queried appendix criteria. And as you know, we have to evaluate uh, some headache types in the appendix. By this way, we can confirm and re-evaluate and improve ICHD criteria in the future. And as you see, the gender differences between the groups, uh, uh, unfortunately, the woman dominancy took our attention again, and middle-aged individuals were affected by headache, all types. And the other interesting information, there were more than one diagnosis in 36.1% of patients. In this figure, you can see the difference in numeric rating scale between the regions. In the Ivory Coast and Sudan, the headache severity was lower when we compare with the other countries. It was another interesting results, and this results uh, when we saw this result, we consider it can be related to pain perception between the patients. In this figure, we try to show all headache types and ratios, and migraine encompasses a very big area between the other headache types, and the tension type headache follows migraine. And we know the tension type headache is the most common headache type around the world, but in the neurologic clinics, uh, migraine is the most headache type because we know there are some reasons of it, because especially in the migraine headache, the headache severity is higher than tension type headache. In this table, we try to discriminate migraine and tension type headache features and demographic uh, 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 clinical characteristics and demographic features between the regions. And both migraine and tension type groups in the Middle East, frequency of headache is higher, and lifetime pain duration also was higher. But in contrast, in the Africa, both of these results were lower. And the same condition is valid for the tension type headache. And it is another interesting result for us because uh, it reflects the individual's reaction to the headache. And we couldn't explain these results only with uh, a matter. It is very complex, and we need to clarify these results. Also, we researched other primary headache disorders. Uh, uh, when we research and read the other articles, I realize especially other primary headache disorders and the other secondary headache types, usually didn't evaluated, haven't evaluated before. And uh, our research clarified this um, lack of the science. Also, we researched and evaluated gender differences, headache severities between the other primary headache disorder groups, and location and uh, lateralizations were researched in the other primary headache disorders. As you see in this figure, uh, between the secondary headache types, headache attributed to a substance and or its withdrawal is the most common headache type in the secondary headache group, and it's very important. And the medication overuse headache, the most uh, secondary headache type. Uh, it is very important because we know this problem increases the time goes by, and in the future maybe it can be the biggest problem in the headache field. So we have to find some prevention methods. In this table, the headache attributed the infection, when we evaluated the headache attribution, the infection in the Africa region, uh, infection-related headaches ratio was lower when we compared the other regions. It was so interesting because uh, before this study, we thought um, we thought we can find higher ratio in this Africa. We consider maybe the health policy can be effective uh, uh, to take under control the infection ratios. On the other hand, maybe the patients with uh, headache attributed to infection uh, do not want to apply the headache center or practitioners, general practitioners. We don't know, but we know we should uh, research more. Um, in this figure, you can see patients who referred to the neurology clinics from different clinical settings, such as emergency services, other specialty clinics, and private offices. Uh, I couldn't find any research like this, and we found some interesting results. For example, as you see, primary headaches ratio is so higher in this group, 92.3%. It's very high. And the woman dominancy took our attention again. And um, we found another interesting results. For example, in the emergency services, male ratio, uh, male male patients ratio is higher when we compare with the other clinical settings. Yes, we expect that, but we have to find why. And on the other hand, lifetime pain duration and frequency of headache uh, ratios uh, were higher in the private offices. And I couldn't find any research related to this information. It is another important result, and we thought it can be related that uh, patients with persistent headache usually refer to the private offices, maybe, and we need more research. Uh, and we evaluated all headache types in the different clinical settings, and tension type headaches usually referred from the other specialty clinics. And that means uh, physicians except neurologists can not uh, cannot diagnose tension type headache truly. And that means we have to arrange some education programs for the other physicians. And especially is headache attributed to somatization disorders were consulted by from the emergency service. And it is another important results because this group uh, can try to apply only emergency service. Maybe they try to avoid to apply psychiatrist or neurologist. Uh, I would like to mention strengths, points, and limitations, and I would like to give some advice related to this research. Synchronized evaluation of patients in different geographic locations by neurologists with a clear protocol, delivering preliminary training on ICHD-3 criteria to physicians before the study, including not only outpatients, but also patients referred uh, from different clinical settings, including regions that represent a significant part of the world's geography and are not frequently represented in previous studies, reporting the current frequencies of headache related to COVID-19 disease, its secondary complications, and its vaccine-related headaches, and revealing the significant difference in the pain severity in different countries by adhering to the same scale. Although this study covers a large geographic area, more countries and centers are required to represent the relevant regions fully. Research must be designed to represent the different regions efficiently. The study period was short. Longitudinal studies can be more beneficial in comprehending the potential environmental and cultural impacts on headache types, subtypes, uh, for example, fasting, circadian rhythms, seasons differences. Some characteristics must be considered, such as race, cultural level, and education. Researchers should consider the language barriers, ethical concerns, and health policies of governments. Before designing an international study, provide proper time for researchers to complete ethical approval and prepare consent forms according to the regional native languages. Since our research is hospital-based, it's not appropriate to generalize its results to the population. Future studies may be performed door-to-door in the general population. Besides, researchers should keep in mind that patients do not have the same chance of reaching health centers and neurologists. Finally, every team member should notice how effective collaboration, good communication, and powerful support are in reducing the burden of headaches on the world. Everything is for a headache-free world. Thank you so much.
Thank you very much, Dr. Genç.
Thank you.
Let me ask a question first. When did you start collecting the data for the MENA study? And what was the ratio of COVID-19 headache among the other headaches?
Um, we conducted this study in the COVID-19 pandemic and in the Ramadan uh, month period. And uh, actually, I mentioned we need the longitudinal study because both conditions can affect our study level, our studies results, and we found COVID-19, the headache attributed to COVID-19 was 3.5%, and headache attributed to secondary complications of COVID-19 was 1.2%. And finally, headache attributed to COVID-19 vaccine was 1.5%. It was important because we know approximately uh, uh, 25% of COVID-19 patients had headache, and only 3% of them applied to the neurologist.
Uh, Actually, I have one more question. In your opinion, why the frequencies and the intensities of primary headaches were lower in Africa compared to Middle East and Turkey?
Uh, Actually, I found a few reasons. For example, maybe uh, their pain perception, it can be related to pain perception between the ethnicity, and uh, um, there can be some underlying mechanisms, pathophysiological or social cultural, because some people try to handle their headache with some traditional methods, and uh, all of these informations show us there are many different environmental or biological mechanisms can be underlying of this result.
Do we have any other questions?
One question from the audience, I think.
Yeah, we have one more question from Ece Yanık. The data for prophylactic treatment, especially for medication overuse headache patients?
In this research, we only focused the distribution of headache types and subtypes. We didn't evaluate the treatments.
Yeah, maybe in the future.
Maybe.
In the next studies, next research, maybe.
Thank you very much once again, Dr.
Thank you so much.
Genç. Uh,
Let me
maybe,
summarize
maybe you can
the
summarize our webinar.
the take-home message of those webinars. And in the first part of our webinar, Associate Professor Safa Zahane from Morocco presented first a case with a thunderclap headache, and she mentioned that a careful questioning and detailed neurological examinations and taking care of red flags are very important for the diagnosis and for acute, for correct and accurate diagnosis of secondary headaches. And in their patients, they have found, they have revealed cerebral aneurysm on the middle cerebral artery. And in the second part, their colleague Hamid Genç presented the MENA study reporting findings from a large geographical area, and that also reveals differentiations between different regions in the MENA region in a very structured manner. And I want to thank all the attendees for joining the first webinar of our webinar series. We hope to meet each other in the next webinar that will probably be in the next week, during the first month of the new year. And thanks again to our speakers for their valuable thoughts.
Thank you.
Thank you so much.
Nice to meet you.
Professor Özge is with us now.
Actually, I am very happy to see each of you here and to discuss very kind of the case and very fruitful discussions, and also another published materials of this collaboration. I hope if you repeat this kind of webinar series, end of the day, we will have much more motivated young colleagues to join with us, and also we will create much more fruitful collaboration altogether as did before. Thank you, thank you, thank you.
Thank you so much.
Thank you very much for your time and participation. I think we can close the webinar. Once again, thank you.
Thank you so much.
Maybe we
Nice
can
evening.
take a
Bye.
picture all together. Hamid, can you stop your screen sharing
Stop
and
sharing.
we can see everybody else on the
Okay.
same screen somehow?
Okay.
Or can you? Yeah, that's great. If everybody agrees, can you open the camera and we can take a family photo all together?
Okay.
We are waiting just 1 minute to everybody will be ready maybe. And that's great to see everybody else face. That's great. Wow. And also screenshot somehow. Okay, I am taking in regular way a photo. Everybody agrees? 1, 2, and 3. Shot. Thank you.
Thank you so much.
Esme and Dua, you can close. Okay.
Thank you once again for the participation, for being with us today on this first webinar. We will meet again in January. Esme?
Yep. So, bye, Spiro. Close the Zoom, I think.
Yeah.
Bye-bye.
Bye.
Have a nice
Bye.
evening. Bye.
Bye.